Hello and welcome to Understanding the ADA, Obligations and Opportunities. For this webinar, attendees will be in listen-only mode. If you need technical assistance, please submit your request under the Tech tab on your screen. If you wish to submit a question during the presentation, please use the Q&A window on your screen. We will try to answer all questions during the webinar, but if an in-depth answer is needed or if we run out of time, we will try to answer your questions at a later time via email. The presentation will now be turned over to the session moderator.
Hello, my name is Reagan Rush. It is a pleasure to be here with you today. I am the Principal Deputy Chief at the Special Litigation Section in the Civil Rights Division at DOJ. I primarily work on ADA cases that involve people with mental health disabilities, and I'm joined by my colleague, Tim Maggette. Tim is a Deputy Chief in our section who oversees many of our police cases. Tim has also developed a focus on ADA and policing issues. And our third presenter is Dr. Kevin Ann Huckshorn. Kevin is an expert in mental health programs and administration. She is currently with Recovery Innovations, a crisis services provider. And Kevin was previously the mental health director in Delaware and led successful resolution of a DOJ settlement with my office regarding people with mental illness. Today, I'll start with a high-level overview of the ADA and how it applies to crisis response systems. Then I'll turn it over to Tim, who will talk more about policing of people in crisis and some of the lessons learned from DOJ cases in Seattle and Baltimore. Then Kevin will talk about her experience in Delaware, being on the other side of the table in a DOJ action. How she and her colleagues in Delaware used the DOJ case as an opportunity and the kinds of remedies implemented in that case that could help other jurisdictions avoid liability in the first place. We'll try to save some time at the end for questions. If you do have questions during the presentation, please put them in the chat box. Starting with the ADA overview, the ADA is a broad civil rights statute that prohibits discrimination against people with disabilities and those perceived to have disabilities, including those with mental illness and intellectual and developmental disabilities. Title II of the ADA applies to activities, programs, and services by state and local governments. That would include 911 call centers, police services, public mental health services, and state Medicaid programs. Note that Title II of the ADA does not require a showing of intent to discriminate. Discrimination, no matter how unintentional, uninformed, or even well-intentioned, is still discrimination under the Americans with Disabilities Act. Discrimination under the ADA can take many different forms. These are some of the most common that may come into play when looking at a crisis response system. First, unequal treatment, unequal access, or unequal opportunity. Collectively, this could involve treating people with disabilities worse than those without because of their disability, or even because of a particular disability type, such as people with mental illness. For example, arresting someone for a minor infraction because they have mental illness when the officer normally wouldn't arrest for that infraction could be discrimination under the ADA. Another form of discrimination is the failure to provide effective communication. So under Title II, a public entity must take steps when necessary to enable a person with a disability to communicate effectively. The obligation is most commonly associated with people who are deaf or blind, but can also be for people with mental illness or who have intellectual developmental disabilities. Effective communication could include arranging for a sign language interpreter, use of tablets to read what's being conveyed verbally, or by checking understanding by asking people to explain communication in their own words. The last category I'll touch on is the unnecessary segregation of people with disabilities. This kind of discrimination is often referred to as the ADA's integration mandate or the Olmstead obligation after a relevant Supreme Court case. This obligation requires public entities to avoid needlessly congregating or segregating people with disabilities in the provision of public services. This often comes up in cases of disability institutions. For an example, if someone with mental illness can be supported in the community with services, then the state or relevant public entity must serve them in the community rather than in a psychiatric hospital. This obligation can be particularly important when you're thinking about building an alternative crisis response system. The way to comply with Olmstead obligations is to implement community-based services such as mobile crisis response teams. And those are the same services that can serve as an alternative to a law enforcement response. And you want to avoid just diverting people to hospital settings if they don't need to be there, because that runs counter to an Olmstead obligation. We'll talk more about an example of an Olmstead case when we discuss Delaware. Now that we've talked a bit about the kinds of discrimination that Title II of the ADA prohibits, and it's important to also note that the ADA places an affirmative obligation on public entities to take steps to avoid that discrimination. These affirmative steps are often called reasonable modifications. They're changes to the regular operation of a program, service, or activity. For example, a reasonable modification in an Olmstead case is to provide those community-based services and supports rather than to, say, leave people with no choice but to receive those services in a segregated institutional setting. A reasonable modification in a policing scenario may be using de-escalation techniques. A reasonable modification could also be an alternative response to a 911 mental health crisis call, if necessary, to avoid discrimination. Obligations under Title II of the ADA are subject to limitations. For an example, if an individual poses a direct threat that can't be mitigated or eliminated by reasonable modifications, then there would be no need or no obligation to provide modifications to that individual. But it's very important that that assessment be based on actual risk, not speculation, stereotypes, or generalizations about individuals with disabilities. So that's the ADA and crisis response system obligations in a nutshell. Now I'm going to turn it over to Tim Maggette to talk about policing of people in crisis. Tim?
Hi, everybody. Once again, I'm Tim Maggette. I'm the Deputy Chief in the Civil Rights Division here at DOJ. I'm going to talk a little bit about DOJ's experience with policing and the Americans with Disabilities Act. And I want to start with this quote that I have on the slide from David Brown from July of 2016. David Brown was the former Dallas police chief and was in Dallas at the time he said this, and now he's the current chief or superintendent of the Chicago police. And I bring this up because I think it gets at a lot of what DOJ has seen over the last few years. You know, as it says on the screen there, one of the things that David Brown says is that, you know, we're asking cops to do too much in this country. Every societal failure, we put it off on the cops to solve. Not enough mental health funding, let the cops handle it. And he goes on and then says, you know, policing was never meant to solve all these problems. And I think, you know, I raise this because I think it does get at something that we've seen, DOJ has seen in its work investigating police departments for of police misconduct. And it really gets at this question of, are we asking the police to play the right role right now within establishing public safety? And specifically with regard to the Americans with Disabilities Act, one of the things that we've seen over the last several years is police regularly interacting with people with disabilities, people who are in crisis, who have mental illness or some other disability. And it is unfortunately, in our experience, at times leading to bad outcomes, particularly in the use of excessive force. So in the next slide here, one of the things that we're talking about is over the last 10 years of doing these investigations, we saw numerous times where excessive force was used in violation of the Fourth Amendment in circumstances that involved people with disabilities and who are in crisis. And so, the oldest one on here, and they're not in chronological order, we started the New Orleans investigation back in 2010, and then the others followed on thereafter through 2011 all the way up until Baltimore and Chicago were launched in 2015. And in each of these cases that's listed here, and in some of the other cases, that officers were using force against people with disabilities or in crisis and in ways that violated the Fourth Amendment. These cases often involved individuals with serious mental illness. Sometimes these individuals were no longer on their medications and they were decompensating. We also saw a number of circumstances of people with suicidal ideation. And many of these calls actually came into the police through family members or other concerned individuals who were actually trying to get help for the individual who was in crisis, but the police response was not always appropriate to the situation that the officers were confronting. And again, part of that is because the officers were maybe not the best people to be confronting that circumstance. Very briefly, just to explain the Fourth Amendment requirements here and give a quick overview of that. Under the Fourth Amendment, force used must be reasonable, and there's a famous Supreme Court decision called Graham v. Connor that gets at this. And essentially, the test that's laid out in there is a balancing test, balancing of factors under what's called the totality of the circumstances. It's kind of a term of art in the law. But for force, it looks at three specific issues. First of all, the severity of the crime at issue. Second, the immediate threat to safety of officers or others. And then third, the level of resistance offered by the individual. And what we saw in our investigations, the ones that I laid out in the previous slide, is that very often we were finding that the officers were responding to situations where the offense was actually a low-level offense, and in many circumstances, the offense may have been related to the underlying disability itself. So a circumstance like disorderly conduct was the underlying charge. We also saw a number of circumstances where the person who was involved in the situation, in the incident, was more a threat to themselves than to others. A person who was exhibiting suicidal ideation, for example, was the only threat was really to themselves and not to another person in the situation. So, some courts, in looking at these circumstances, have then gone on to say that, look, in those types of circumstances, the police department needs to have a different response under the Fourth Amendment. So officers, here's two examples, two quotes from a Fourth Circuit case back from 2016 that get at this. One saying that, officers who encounter an unarmed and minimally threatening individual who is exhibiting signs of mental health issues must de-escalate the situation and adjust the application of force downward. So, recognizing that the person's disability requires under the Fourth Amendment a different response than it might be for a person who does not have that disability. Similarly, where The court goes on in that same case to say where a seizure's sole justification is preventing harm to the subject, for example, a person who is suicidal, the government who has little interest in using force to effect that seizure, what happens in effect is that the individual may be attempting something called suicide by cop. It's a frequently used phrase, and that's exactly not what the officers want to do, and it puts the officers in a terrible situation where they are confronting that individual, and if they don't have the proper skills to interact with the individual, it could end up being harmful to the individual, and it's obviously also harmful to the officers themselves when they use force in such a circumstance. So those were the kind of original lenses that we looked at. A lot of our work under was the Fourth Amendment, and more recently have moved to looking at this work under the Americans with Disabilities Act as well. And Reagan already laid out what the requirements of the Americans with Disabilities Act are. I want to use two specific case examples to dig a little bit deeper on how this has played out for DOJ and our experience. The first is what I'll call the Seattle story. We launched an investigation of the Seattle Police Department in March of 2011. We were specifically focused, principally focused in that investigation on whether or not the Seattle Police Department was using excessive force. There had been a number of high-profile incidents involving the use of force in the Seattle Police Department, and there was significant community outcry that was part of what led to our decision to go in and investigate the Seattle Police Department. At the end of 2011, in December of 2011, we found that the Seattle Police Department was using what we call a pattern or practice of excessive force. So committed or practice of Fourth Amendment violations, and that part of that pattern or practice was the use of force against individuals who were in crisis or otherwise had a disability. We negotiated a consent decree with the City of Seattle, which we entered in the summer of 2012, and part of the remedies that were included in that consent decree were CIT, crisis intervention team and crisis intervention programs that were focused principally on creating new policies and then training the officers on how to interact with individuals who are in crisis. And I think this is an important remedy and one that's necessary. But as we'll see, I think it maybe doesn't get at all the issues that we want to be able to get at to prevent these types of circumstances from coming up. The other thing that was included in that consent decree and that the City of Seattle took on was more extensive data gathering around its interactions, its police officers' interactions with people with disabilities. And so by the time we hit 2015 and 2016, as you can see on the slide, SPD was able to start gathering, collecting, and then analyzing data that showed that there were over 9,000 unique crisis incidents per year on average over those 2 years. And those are, when I say unique crisis incidents, those are incidents in which a police officer was dispatched or on a more rare occasion had what we call an on-view interaction with a person in crisis. But the data went on to show, as you can see on the remainder of the slide, that very few of those interactions actually required police intervention. Only 8% of those crisis incidents resulted in an arrest of any kind. Even less than that, only 1.6% of those incidents resulted in force being used, and only 0.4% in greater than the lowest level of force. And low-level force in Seattle is defined as essentially, anything above unresisted handcuffing. So it's a fairly low level that for the most part, most of these incidents involved. So that's a pretty small number in which the police department actually had to take action themselves. As we go on to see here, instead, the data showed that for more than 20% of the interactions, no action was possible or necessary for the police department to take place. So they had an incident, but there was no action for the police officers to take. In another 15 to 20%, you had individuals who declined any kind of resources or referral from the police officers. And more than 33% of those individuals were diverted to medical care. So while there may have been some policing issue involved here, for the most part, this could be handled exclusively through medical care of some kind rather than police action, rather than an arrest or any kind of force being used. So overall, we're talking about a huge percentage of these incidents, these crisis incidents, actually needed very little police interaction altogether. SPD and the City of Seattle are continuing to use this data now to try and derive their analysis of how they can better deliver public safety in the City of Seattle, and what kind of resources they need to put in place to support individuals with disabilities. And so one of the things they're looking at is using the data to identify people who are called high utilizers of policing services. For these individuals, they had frequent police interactions, and they were kind of cycling over and over back out to the police, in part because there were not the right crisis services in place, or just even the long-term stability services in place to prevent the person from continuing to go back into crisis. And by tracking this data, the City of Seattle and the Seattle Police Department was starting to be able to see that they were, some of these individuals were coming back to them over and over again, and they really needed different services to be able to help that individual and not have them frequently interacting with the police. The city is also using this data to help build out a non-police response system, and they've started a number of different programs along those lines. A lot of that is still in process in the City of Seattle, and I'm not trying to suggest that they've arrived in any way, but they're using this data to help them drive new practices within the city, a lot of which are very promising. The next story I want to talk a little bit about is the Baltimore story, which is much earlier on. As I alluded to earlier, we launched an investigation of the Baltimore Police Department in 2015 and released findings of that investigation in August of 2016. And in that investigation, we found violations not only of the Fourth Amendment, like we did in Seattle and some other places, but also violations of the Americans with Disabilities Act, using the standards that Reagan laid out earlier in this presentation. And so, once again, the City of Baltimore was interested in reforming these practices, and they entered into a consent decree with us in January of 2017. And the remedies that are included in that consent decree include some things that we included in some of our earlier consent decrees, things like the crisis intervention program that the Baltimore Police Department engaged in, but it also included some new programs that were different than anything that we had otherwise had in a consent decree previously. And some of that was rooted in the fact that we made findings of violations under the Americans with Disabilities Act. And so two areas that we were specifically focused on were dispatcher training, so that calls for service related to crises that did not necessitate a police response could be sent to other crisis services in the first place, essentially getting police out of the equation when they didn't need to be involved. And so trying to train those dispatchers to be able to determine what type of call this was, whether or not a police response was necessary, or whether or not some other kind of service could do a better job and avoid the need for the police to respond at all. And then the second and kind of major new thing that was in the Baltimore consent decree was the city agreeing to perform a gaps analysis of their behavioral health service system, recommend solutions based off of the gaps that it found, and then try to assist in implementation and carry out an implementation of these new solutions. So the focus here really was on trying to look at not just the police department and what the police department needed to try and do and change in order to be able to have better outcomes by police interactions with individuals with disabilities, but really what does the overall service system need to do to reduce the necessity for police officers to be even responding to that situation in the first place, reduce the likelihood that a person is going to be going into crisis and necessitate any kind of response. And so what kind of system needs to be set up? So just have time here briefly to describe a little bit of the findings of the Baltimore Gaps Analysis, and it's a substantial document. I think it's well over 100 pages if I'm remembering correctly. But I just wanted to pull out a couple of the findings that it includes. One of which was to expand community-based mobile crisis response teams. It's something we're seeing as a major emphasis across the country right now. But this was something that, according to the GAPS analysis, as they looked at and studied Baltimore's system, was contributing, the lack of having these community-based mobile crisis response teams was contributing to unnecessary police interactions and contributing to the strains that the police department was facing in trying to provide public safety. Another area that it recommended in expansion was of residential crisis and peer-led respite beds. They need to be accessible 24 hours a day, 7 days a week. This is something that was critical to expanding as well. And then the last one, it talked about supported housing and employment, as well as ongoing mental health services. Each areas that needed to be explored and expanded in order to prevent these unnecessary police interactions. And there's a quote there on the right-hand side that emphasizes exactly that. The GAPS analysis found that enhancing these types of community-based services will greatly relieve the pressures currently observed on law enforcement and other first responders, emergency departments, and inpatient beds. And so it's the building out of these additional of these community services that are the key to really relieving those pressures on law enforcement, to putting the police department in a better position to succeed and to provide community safety more effectively. Not on this slide, but just recently, the city Baltimore has released a plan to implement many of the reforms that are in the GAPS analysis, which is very encouraging. And the city has reiterated over and over again that they now see that this is the best path forward for them in Baltimore, and they're committed to doing this work. So we're really optimistic. Again, that work is ongoing, and I don't purport to say that it's all the way there, but it is a very positive move in the right direction to reduce the strains on law enforcement and to reduce those bad outcomes where we have individuals who become subject to excessive force by police officers. But I now want to turn it over to Kevin Ann Huckshorn. She can talk in more detail about how you build out those crisis services, because she led that exact thing in Delaware. So I'm going to kick it over to Kevin Ann to talk about this next example.
Thank you, Ken. Thank you, Tim. I'll jump in just to kind of introduce Delaware. So we're gonna turn from the focus on policing cases to examining a Justice Department Olmstead case and how that case can offer some lessons learned for jurisdictions looking at alternative crisis responses. So Delaware came to our attention because of obvious problems regarding conditions in the state psychiatric hospital. We then expanded the investigation under the ADA to look at whether people with mental illness needed to be in the hospital in the first place, or whether they could be served in their own communities with appropriate services and supports. We ultimately concluded that, in fact, Delaware was operating an institutional focused mental health system, that people were unnecessarily sent to the state hospital because of a dearth of community mental health services. And we also found unconstitutional conditions in the state hospital. We packaged up our findings into a letter and addressed it to the governor in 2010. And that's when Kevin Ann Huckshorn entered the picture as the newly hired mental health director in Delaware. I'll turn it over to Kevin to pick up the story.
Thanks, Reagan. Thank you, Tim. Hello, everybody. Good afternoon. I want to set the context a little bit back in 2010, right about the time when the US DOJ letter of findings were received by us. So in terms of the behavioral health service system, there was a heavy reliance on police and emergency departments to respond to any kinds of behavioral health crises outside of a hospital. There was a lack of community services, and what I mean by that was there was no peer support services in place, no ACT teams, ICM teams. Most folks were living in congregate housing developments. And in general, although everybody was doing the best they could, there really had been no new money for a really long time. And the state had not pursued a Medicaid waiver at that time either. So what happened was when the letter came in, we used the letter of findings and sat down with the AG's office, the governor's office, and the secretary's office of DHSS, and with our newly appointed monitor, settlement agreement monitor, Bob Bernstein, we developed a plan going forward. And I have to tell you, the governor, the secretary, and the AG's office took a very important lead role in this work. And our monitor, Bob Bernstein, was also critically important and actually did a lot of the work hands-on himself in the first couple of years. So one of the reasons that leadership was so important is not only because whenever you're trying to do a large system culture change, you really can't do it without that type of executive leadership on the helm. But we also needed to engage the legislature. And because of their involvement, we were able to engage the legislature because we knew coming up pretty soon we were going to need a chunk of money for what I call bridge funding. Bridge funding is what you need when you are going to start to develop a new system, but you're having to operate the old system at the same time, and nobody's giving you any money to do a separate system. So we needed, and I believe what ended up happening the first year was we got $10 million from the legislature to start standing up some of these programs that we had identified as critically important. Another piece of our response was also important, and that was the development of partnerships all through the state with what I would call stakeholders. So I'm talking about really our advocacy organizations, our emergency departments, our provider folks, just about everybody, the police departments. And we pretty much brought them into play in terms of subcommittees so that we could start to really work on the components of the agreement and the plan, because it was very ambitious and we had to chunk it down. So we started meeting with, the state hospital, the people that were going to start to develop the ACT and ICM RFPs. We had to stand up a housing program. We needed to start to look for diversion services because, again, we had this reliance on people would be picked up, brought to an emergency room, and then put in a hospital or involved in the legal system. We also needed a Medicaid waiver, so we had to do a separate process for that. We needed peer support. We had to do a separate process for that and stand that up. And we wanted to start getting our police trained in CIT, among other things. Meanwhile, the court monitor, we determined that all the citizens of Delaware also needed to know what was going on. It was really, really important. So the court monitor started to do kind of a dog and pony show, if you will, all through the state of Delaware over a period of months, where he would do talks in public forums to explain what the ADA was and what the role was of the different stakeholders and even the citizens of the state. So let's see. So, oops, sorry about that. I don't know how to go back. Can my tech people move me backwards? One more. Sorry. Okay. So in 2016, Delaware was considered to have become compliant with the settlement agreement. And we were very proud of that, obviously, because of all the work that had gone into this real transformation. And what we saw was that we had been able to expand our peer services throughout our entire system. In other words, we went from one peer support staff person in my office to over 120 peers in the state. We also were able to get a Medicaid waiver to start to improve our access to federal funding, and also to open the door to being able to provide many, many more services. We also were able to revise our state involuntary commitment laws. And to do that, we sat in rooms with the emergency department physicians and a lot of the attorneys, and we walked through that so that we could figure out how to best utilize our new our crisis diversion programs, which at that time, that was in about 2000 and I want to say 12, 13, we were able to get what was then Recovery Innovations into the state to set up crisis services, as I'm going to talk about in a minute, in terms of the Crisis Now model. Also, we were able to set up a data tracking system. And in addition, we saw because of primarily the diversion services that we were able to put in place, we saw the decrease in the census at the state hospital by 40%. We saw a decrease in emergency department boarding. We were able to move over 1,000 clients. I think it was more like 1,200 clients from congregate living to supported housing. We were able to increase people getting into job settings, and we decreased hospitalizations overall. So it was a very successful project, but it took, like a village. It took the whole state, to be perfectly honest with you. So, oops, now I'm going backwards. Need to go forwards, folks. Next slide. So in terms of outcomes, we again reduced reliance on the state hospital. We saw a 92% increase in Medicaid eligible citizens of Delaware receiving community-based services. We ended up seeing an 80 to 90% diversion of people from the hospital and criminal justice systems through mobile crisis and our receiving centers. And along with that, very short length of time for police when they came to drop off a person in crisis, less than 3 minutes. And right now it's at less than 2 minutes. And those are the outcomes that you definitely want to see, regardless of if you have a settlement agreement or not. So very quickly, I'm going to walk you through the Crisis Now model. I know that there's a few other presentations today, but if anybody missed one of those, I just think it's really important. This is a very exciting time in behavioral health in the field. I've been in it for 40 years, and this is just very exciting. So what we're looking up is across the country, the stand-up of the Crisis Now model that has come from SAMHSA is considered to be a promising evidence-based practice. And it basically includes 3 core services. And this is important for folks to know, because while there's a whole number of other behavioral health services that are critically important in any system of care, if you're looking at the outcomes you want to expect from crisis, diversion, and service systems like this, these are the core services you need. So first you need the call center hub, which is very similar to, obviously, what we're all used to, 911. 911 works very well. It's probably the only healthcare system in the country where you can pick up a phone, call a number, and someone will show up for sure, no questions asked, and they will help you or take you somewhere. So this model is really based on the 9/11 emergency medical model. And so it calls for setting up a crisis call center that usually is going to be linked with 911. So some folks can be sorted out because there will be calls that come in from folks that do need a police response, who may have a weapon or may be threatening someone else. So occasionally you are going to need police response with mobile crisis. But in general, most of the calls can be handled quite well with mobile crisis, which is the second piece. And that piece, it's also important to understand that we're not just talking about high quality behavioral health care here. We're also talking about efficiency and cost effectiveness. And this model meets both. And one of the ways it does that is that we don't involve law enforcement or EMS, even in the crisis mobile teams here. There's no need for that. What this model calls for is a peer support specialist and a mental health professional that's licensed. And they're on 24/7, no wrong door. And what you try and do is you place these folks in areas of your state or county where they can respond within 20 minutes, 30 at the outset, depending on the nature of your area and whether it's suburban or rural or urban. And then the third component is the crisis receiving center. And that is also, it's important to understand the details because what we're talking about here is what I used to see and work in back in the 80s in the old community mental health center model, which is a 23-hour screening center. Again, no wrong door, nobody gets turned away, 24/7 services, staffed with medical and mental health people, where anybody can come in and get a fast, specialized, behavioral health specialized screening and assessment, and then basically be referred to where their needs will best be met. And so what happens in a small percentage of cases of the folks that come into the 23-hour service system, which is usually, not always, licensed. If you don't have codes yet for crisis services, in some states we've gotten licensed under the outpatient codes. What happens then is if people need a higher level of care for more days, then they go into a 3 to 5 day short-term inpatient stay, which can be co-located on this platform or not. And then the other piece is you most likely want to have a technology platform. And then the umbrella under which these services fall are under the values that we have been talking about for years, where we're talking about safety, trauma-informed care, recovery-oriented care, no force first, customer services. So what are the barriers that police perceive and which is sometimes is an obstacle to launching crisis now services? Well, you know, police are really busy. And if you're a police person and you know you can drive to door A, which is the emergency department, and no one's going to turn you away, and you might have to sit around for a couple hours, but at least you're not going to be turned away, you're going to probably go there more often than not. And the same would go for jails. You bring someone into jail, you drop them off, and you're back on the street. So it's critically important that when we set up these receiving facilities, that we're not sending the message back to police that's been historically the kind of messages that they've gotten. Not too drunk, not drunk enough, what's their BAL, we need mandatory medical clearance, that person's too sick, we just saw that person last week, so we don't want to see them again, who's the insurer. Those things they cannot be a part of a crisis now system, because that's the only way that your police officers will be willing to come and bring people in crisis to us that are working in those centers. So you want designated police entrances for safety. You want to keep those as private as possible, sometimes just awnings and things like that, or a half wall can help with that. Again, 24/7. We at Recovery International talk a lot about our staff attitude, which is bring us another person, please, whenever you want. And so in that way, we're now bypassing these very expensive services, which are emergency departments and police involvement. So in terms of the crisis mobile team, the key precepts, we're talking about precepts of a mobile team. they can be different. They can differ a bit. But the core pieces are that they're community-based. They don't run out of hospitals like ambulances. And they are not partnered. The team that goes out is not partnered with EMS or police. We also want them to really focus on crisis intervention and de-escalation, trying to develop a safety plan right there on the street, find out who friends, family supports are, and then, if necessary, arrange for that higher level of care. So you can see, for those of you in many other states who are on this line, this conference, you're going to need to look at your involuntary laws, like we did in Delaware, to make that this all fit together. We also really expect mobile crisis to, they keep documentation, they keep data, and they do follow-up, often the next day. So again, as I mentioned before, the goal is a 20 minutes response time. The team is we call a mental health professional, a licensed person, and a peer. We're looking at top outcome to be jail and ED diversion, and the fact that a majority of these responses have not required law enforcement. So this is just some data from one of our larger states, just to kind of give you a little bit of a picture on how this works. So this particular facility, crisis center, sees about 20,000 crisis calls a month. Less than 10% result in mobile crisis dispatch. So what that means is our trained call center staff can handle the majority of these crisis calls just on the phone. So for the 10% who can't, mobile crisis gets dispatched. Another key point is that less than 1% of those calls result in a police response. And that's usually worked out between the call center and the 911 system, sometimes with a intercept model that basically has key decision points on when you send the police and when you don't. And those have already been developed, so no need to start all over. Then what happens is, in that particular crisis centers, about 1,600 mobile team responses a month. Less than 10% of the mobile team responses required police, like as above. Roughly 75% of the mobile team responses stabilize the individual in the community, so they don't have to go anywhere. And of those who need a higher level of care, less than 3% had to go into a med-surg emergency department. So minimal use of ambulances, which is anybody who's been involved with anything like that lately knows they have become extraordinarily expensive. The next step is the crisis observation, or the 23-hour services. And that's where we see about 70 to 80% of the folks that actually make it into that service get discharged back to the community within that 23 hours. And then for those of the folks that were not able to complete they weren't able to get to stabilize in that 23 hours, there's about 20% or so that end up going into the higher level of care. And about 70% do not complete the involuntary process. So in other words, those are the folks that were able to be let go. So it's about 30% that end up being having to be continued involuntary. So I'm going to stop there. I think the only thing I wanted to end up with was the in terms of like lessons learned from the Delaware experience. I think the most important thing that we learned was that you have to do this in partnership with your stakeholders. You have got to do this under an umbrella of very strong executive leadership. It doesn't probably necessarily have to be the governor, but I can tell you that for me, in my position in Delaware for that number of years, having the governor and actually in lieu, the secretary in lieu of the governor, the AG's office, the court monitor, was just critically important. In terms of creating partnerships, our Mental Health Association in Delaware was critical. They were a leader throughout the entire process. They ended up actually becoming a provider of peer support services. NAMI, our P&A, law enforcement and corrections, the legislature, if you can find some key legislators to really delve into this and understand what needs to happen so they can really be helpful. Our community providers, of course, they're like the lifeblood of the system, and our Medicaid office. And then I guess the last thing I'd mention, for those of you who maybe haven't had a chance to read up on the Crisis Now model, if you Google SAMHSA and Crisis Now, that toolkit will come up, and it explains the model in very well, very articulately. It's not very long document. So I really strongly recommend that everybody check that out, because 988 is coming soon, and our system is going to change as a result. So thank you very much, and I'm going to turn this back over to Reagan. I think you're muted.
Whoops, thank you. Thanks so much, Kevin Ann. I'd like to go ahead and encourage folks, if you have questions, to please put them in the chat, and we will try to get to your questions at this time. I'd like to go ahead and turn it back over to Tim, who I think has a follow-up question for you, Kevin.
Oh.
Yeah, Kevin, hearing your presentation reminded me, one of the things that I've seen quite a bit in interacting with local police departments is a lot of them feeling kind of helpless to be able to change the community services in their area, and not knowing what to do to try and create that change. I recall a sheriff in one of my investigations who admitted to me that he was holding people longer than he ought to, which is a Fourth Amendment violation. So it was pretty striking that he asked it, but said that he was doing so because he knew that person was just going to go back out into the street, and he didn't have a place to be able to take that person to, and he was very worried about that, and so he didn't feel like it was the right thing to do, is just to release the person. So I guess the question is just, how should a local jurisdiction, a local police department, how can they work with the state to set up community services locally and reduce reliance on the police and make sure that they actually have those services there that they want?
Yeah, it's a tough question, and it's a tough goal to resolve, or a tough challenge to resolve. I know in some states what's happened is that someone in the state, usually one of our behavioral health advocacy groups, have reached out to the police and introduced CIT, or mental health first aid, as a beginning point. So, because police don't get very much in their training on behavioral health emergencies, and what they do get is often in the first couple weeks, and maybe with a little refresher once a year. So they're having to learn all kinds of other things too, and so and they don't sometimes deal with it every day. So it's really not information that they sometimes hold on to. So getting folks involved in critical incident, in the CIT training sessions, and linked into all the other CIT trained police departments in the entire country is sometimes a very effective way to help police departments start working with each other, even if they're in different states or different counties, to find out what people did that worked and what people did that didn't. I just came back from the CIT conference in Arizona, and pretty much every state was almost represented there. It was an enormous amount of people, and lots of exciting developments and things. The other piece is that I think if you're the state behavioral health entity, it's really critical to reach out to some of your sheriffs and some of your local law enforcement, at least just to get a meeting at the beginning of your tenure, or whatever you want to call it, so you can just find out from them the challenges that they're experiencing on the street, and you can put that information into your plan development, whether you have a consent decree or a settlement agreement, or you're just going forward to try and implement Crisis Now. That's what we ended up doing. I can tell you, when I went to Delaware that first year, I would never even thought about meeting with law enforcement. I hadn't really thought about it. I was focused on where are our ACT teams and where's our peer support. So I think it's important to understand the criticality of partnering with our law enforcement people in this system, because they touch people that we serve about as much as we do, in retrospect. So thanks, Tim.
And Tim, another thought that has come up a bit with our Olmsted cases that could be another strategy to consider there is the local police department approaching the local community mental health center and whatever sort of entity is in that police jurisdiction's caption area, and sort of pairing up with them and sometimes local advocates. Every state has a federally designated protection and advocacy organization for people with disabilities. And so we've seen some pretty creative partnerships between police departments, local sheriffs, the local community mental health center, and advocates get together and then jointly approach the state Medicaid or mental health agency to say, look, this is really what we collectively as a community need in terms of community mental health services, because here's the problems we're seeing and the high numbers of folks with mental illness interacting with law enforcement and ending up in the jail. And I think that can be, we have seen as a way to sort of get the attention of state leaders.
Yeah, and I guess if I could just mention, for states that are, small like Delaware, don't have a consent decree, don't have, money growing on trees, you don't have to set up all, 4 components of the Crisis Now model all at once. You really don't. As in Delaware, we just set up our first 23-hour receiving facility. We didn't have mobile crisis yet. We certainly didn't have a call center. We still don't have a call center. We have a line that people can call. I believe it's the suicide hotline. So things do eventually get to the place they need to go. But so you can start small and you can start in pieces. And, some states have mobile crisis, but they only work, 8 to 5. Well, that's better than nothing. And with the new money coming down through the American Recovery Act and through SAMHSA and through the block grant and through a lot of other grants and waivers and things, there's money to start and then grow. So don't think you have to have enough, millions of dollars to do the whole thing in one fell swoop. You don't.
I think that's really helpful, and thank you for kind of talking that through. I mean, in some ways, it seems like it's so important both for the state level folks to be thinking and trying to reach down to their local stakeholders and their local police departments, but also obviously it's got to go the other direction. And if you've got, the local leadership and they can partner with local advocates and local protection and advocacy organization and others, they can kind of push it back up in that way as well. In some ways, I think that gets to one of the questions seeing in the chat about kind of how to getting this message to the local jurisdictions and, if they're not receptive and whatnot. I mean, some of it does maybe need to be at times that top-down approach because some jurisdictions might not be looking to it themselves, but then there's others that are, and they need to be trying to push it as well. And I think from what I've seen, at least with police departments, the way you get the best reception is when they start to see it working well in other local agencies around them. And so when they see other police departments doing this and doing this effectively, they say, oh, this is something that we want to be able to do too, because it's something that really works, and we've seen it work in other law enforcement agencies. So, that's all really helpful. Thanks, Kevin, and thanks, Reagan, for that idea.
Yeah, and I was also just thinking a little bit about just the correctional system also, because the jails need to be involved if you have jails in your communities, because LA County is the biggest mental health institution in the country, LA County Jail, and so that's another place to get some engagement and some training going, so you don't forget that part of the system.
That's a very great point, Kevin, and I think sheriffs and jails can be good partners in this. We also have a question from the listeners, and a really good one that, Tim, I'm gonna punt to you here. How will departments find time to interject these additional training? One problem I found working in social work is the amount of time spent on trainings, documentations, and other paperwork, and very little to no time serving clients.
So I guess that's a great question, and I think I'll answer it maybe in kind of 2 or 3 different ways. The first way I would say is, I think Kevin alluded to this a little bit already, but I do think that a lot of departments that we've been working with have been trying to weave these trainings directly into their initial trainings for officers when they first come on board, so that they have these tools in their tool belt from the very beginning of the time they begin as officers. And I think that's an important stage to make sure that you're reaching officers and helping them to see that there is some way to try to build this in. And I think that police departments are interested in doing it because they're seeing that they get better outcomes out of this. It's not only a good tool to help them, be better police officers, but it reduces liability for the overall department when you have the officers responding appropriately to those situations. I think that you also need to kind of think about how you're going to do your in-service training, your regular training over time for these officers to make sure that they're continually updated in it. But I think that those are kind of 2 things that don't necessarily say, well, wait, but that just means more training, right? I think one way to think about this is I don't know that every officer needs to be trained to the highest level of, doing crisis intervention. You can have officers who are trained at the basic level of crisis so that they understand a little bit of what they're looking at. But then you also, most departments that I've worked with use a specialized team of crisis intervention officers to deal with the harder situations and make sure that those ones are ones that you get the crisis intervention officers actually dispatched to. And so that's a lesser training strain on the overall department because you're training a specialized team to help handle those specific situations and then get that diverted over to your mobile crisis teams and others in the first place. Because I think that gets to kind of the third answer to this, which is, do you need to have all of your officers responding to all of these calls? What if we were talking about training mobile crisis teams, training other types of community services to be the primary responders to so many of these calls in the first place? Of those 9,000 annual calls in Seattle that I alluded to earlier, what if the vast majority of those calls are not being responded to by the police at all? Then you're freeing up those officers to be able to engage in other policing activities that are more essential for them and not dispatching them to situations they don't need to be responding to in the first place. And you can give specialized training to the people who are better situated to actually be responding to and helping with that call overall. You're muted again, Reagan.
I sure am. Thank you. All right. It looks like we have another good question from the listeners, and that is that it sounds like data is important to help make the case for resources as well as understand progress and system change. And are there key indicators that you would suggest that a state may want to pay particular attention to, especially related to Olmsted? I can kick this off, and Kevin or Tim, y'all should feel free to chime in too if you have more, but certainly data is an incredibly important place to start that I'd recommend any state or local government really start by analyzing this. I think on the statewide level, it's important for states to truly understand where their resources are going and sort of have an institutional inventory and utilization of those. Where are people with mental illness, especially sort of where are they being served? Nursing facilities, adult care homes, psychiatric facilities, cycling in and out of those, IMDs. How many beds and facilities are there, and what kind of length of stay and utilization is happening there? And then set up a comparison with the critical community-based services to the extent they exist in the state. Things like mobile crisis that we've talked a lot about this conference, assertive community treatment, permanent supported housing, supported employment, intensive case management. If those services are offered, to the extent are they being utilized in various geographic regions? Sometimes we see in Olmsted situations where some areas have sort of a patchwork of services, and some folks are able to get the full array of services, and others really aren't. And so, really trying to look at the institutional utilization pattern and where your money is going in those institutions, comparing it up against those community services. And then I think the third bucket of data is really looking at the sort of the amount of interaction in criminal justice. So where are you seeing a lot of people with mental illness in jails? And this gets back to our partnerships with sheriffs and law enforcement. Where are law enforcement seeing a lot of interaction with people with mental illness? Because that's a strong sign that they are not getting those community-based services and support. So I think using data to sort of target resources and target where the services are most needed and kind of get the best bang for the buck would make sense from a policy perspective on a state level, but also certainly makes sense from an Olmsted implementation kind of level. So Kevin or Tim, do you have any other thoughts on that question?
Sure. Yeah, I mean, that you covered a lot of the bases, Reagan, but in terms of a system, looking at a system, I think you're going to want to look at the citizens, the numbers of people that you have, and there's formulas for that have serious mental illness, co-occurring disorder. You want to look at their access to care. Where are they getting care? Are they, are there well-known places for people to go in? Are there no eject, no reject policies? When I grew up in Florida a while ago, every single it was in our regulations that every person that was deemed to have a serious mental illness was then immediately deemed a priority client. And as a priority client, no state-funded provider could turn them down. Now, that was definitely years ago, but I've seen a lot of slippage since then across the country. You also want to know what their time in care is, and if it's the correct level of care. And there's all kinds of tools to use that have been validated to do that. And so don't reinvent the wheel, for goodness sake. And then I think last, you're going to want to look at the people that are outside of the system that aren't being able to get in. And those are our homeless folks, the people that made it into jail on nuisance crimes that should never have been diverted in that way. It should have been diverted back to the behavioral health system. You want to look at recidivism rates. And if you're doing crisis diversion, there's a whole slew of data variables that have been well developed and been used for at least more than 2 decades. So those are also accessible in that SAMHSA document to some degree.
One thing I would just add from the policing side of this is that a lot of police departments don't necessarily or haven't historically tracked when they're interacting with a person who is in crisis or has a disability. And one of the things that would be important, I think, for departments to think about is how can they add the ability to track some of that data so that they understand when they are making these contacts and seeing what the volume of the contacts is, and then how do they respond to and reduce that overall. And so, I'm not trying to hold it out as a perfect way of doing it, but the Seattle Police Department, as I talked about earlier, does track all of this crisis data, and a lot of it's online and publicly available in terms of kind of the raw data that you can look at. They have Seattle has its public safety open data portal that you can go in and be able to pull a lot of what their data looks like to be able to do some of the analysis themselves. And they also have produced regularly over the years what they call their crisis intervention program reports. So it looks at some of these different things, but the key to that was actually starting to track those crisis contacts and then start to think a little bit hard along with their crisis intervention committee that's part of their CIT program. What do we then do about this? And so making sure your police department actually has the ability to track some of those interactions in the data and be able to then think about how they use this to be able to be kind of an advocacy tool for how they want to change a way around the community services in their local community.
Thank you, Tim. Kevin, the next question is for you. If you were advising a local jurisdiction that had limited funding, yet interested in building up community services to divert people from criminal justice involvement, where would you recommend they start to really get that biggest bang for their buck?
Well, I mean, obviously, you need to look at your Medicaid plan to see what you can pay for through Medicaid and then figure out what your population size is. So what we usually do if a county or a state comes and asks about setting up a program, we have something called a calculator, which is on our website, and you can put in the population of people that you want to serve, and it will basically, with a couple little clicks, it will kick out how many beds, how many chairs you might need, how many beds you might need, and then you can start to look at, what's it's going to cost. Generally, Medicaid will pay for a good amount of services for most populations in most places, unless you're very, very wealthy. A very, very wealthy county, it gets a little tricky there. So like I'm talking, like, I think the gap funding usually needed is about 30%. Then I would look at, if you're a community that already has a suicide hotline, you probably don't need to worry about a call center right off the bat. If you are, small enough so that you can expect a lot of walk-ins, you maybe don't need to set up mobile crisis right away. But you can set up either mobile crisis or a receiving facility, either or both. Those are the kind of the critical components, I think. And certainly feel free to reach out to any of there's a number of experts in the country. Recovery International is one. NASHBID certainly can help out in directing you to excellent resources to start this conversation. I think pretty much every community needs to start having the conversation, because it's going to take a while to set up new programs, as everybody knows. So, I think it's so individualized to your own community and what your current behavioral health, including IDD system, looks like, that it's hard to kind of carte blanche just say, well, this is the way I would go, because it would be very different depending on the environment I was in. So again, feel free to Google me if you want to have a conversation, or get onto the Recovery International website, and you can track me down or other people down, certainly, to talk to about that information. Thank you.
You're muted again, Reagan.
There we go. Sorry. It looks like we're almost out of time. Tim, I'm going to give you the last word here with 30 seconds to answer the question. For those folks who are attending the conference and building community responder models, what should we keep in mind in order to stay in compliance with the Fourth Amendment and the ADA?
In some ways, I think that's just, what we've already been trying to say here, which is, you got to really think about whether or not your police department is the right one to be responding to a huge number of these incidents. And you got to think about whether or not especially under the ADA, is there a different direction that you should be going in here, locally and as a state, in order to be able to provide the services that people need, and reduce the burdens on your law enforcement agency, in order for it to be able to really concentrate on its core mission, which is public safety, and it's not trying to be the first responder to crisis calls and for individuals with disabilities.
Okay. Thank you very much to our speakers for the presentation today, and I would like to thank our audience. Thank you for your participation in this session, which we hope you've enjoyed. You will now be brought back to the main room for wrap-up and team directions.